Marta.
Thank you very much, Runa. Thank you for the invitation and for having me in this virtual conference. It's a new way we talk and we meet these days, and I'm very pleased to be here with you.
Thank you.
Thank you very much. So my task over the next 20 minutes will be to discuss about lupus and about the clinical picture, but particularly I will discuss with you the development of the 2019 classification criteria for lupus. So we will try to see why we needed to do these criteria and how these criteria were developed. Here you can see the structure of my presentation. I would like just to give an overview of how complex is lupus and discuss a little bit about classification criteria, the early classification of lupus, and then the development of the new criteria. So we know that lupus is very complex, and if we go into our textbooks, we can read that lupus is a prototype multisystem autoimmune disorder. And in patients with lupus, we expect almost everything. So there is no classic pattern of lupus. And in fact, if we see our patients, we see very different stories in different patients and in the same patient over time. Here, just to give an overview of different lupus phenotypes, I prepared the sketches of some patients of our clinic. A female born in 1971 with a disease duration of 16 years and a disease characterized basically by mucocutaneous articular manifestations and serositis. Another patient with a disease duration of 17 years, and she has had mostly kidney involvement and hematological manifestations. Another patient with a disease duration of 11 years, and she has had neurological manifestation along with serositis and hematological involvement. And finally, another patient, and she has had almost everything: skin, joints, kidney, neurological manifestations, serositis, and hematological manifestations. So we very often question whether lupus is one disease or it's a syndrome, and indeed we call one disease, but we have many diseases in front of us. We know that lupus is also very different in different cohorts and is different in different ethnicities. So the clinical picture of lupus is very different. It's characterized by a large variety of clinical manifestations with differences by autoantibodies, by gender, by ethnicity, by age at disease onset. And what we know is that we do not have the biomarker for lupus. So what we do, we describe the disease by the aggregation of symptoms, and we classify the disease based on the association of different clinical and hematological manifestations. Now, we discussed then about classification, and just would like to remind you that there is a big difference between diagnosis and classification. Diagnosis is something we do as doctors, because diagnosis has a clinical implication. It is aimed at the individual, at the single patient. So when we diagnose a patient, the purpose is to treat our patient, and we can discuss the diagnosis as many times as we want. Classification is done for research. And the aim of classification is to define a group of patients, which has to be homogeneous. And what is important is that it's very important to be specific at one time if we consider that we will classify a patient, for example, as an entry criterion in a clinical trial. This is very important to be kept in mind when we analyze classification criteria, as classification criteria will by no means be diagnostic criteria, even though we use them to help us in diagnosing our patients. So criteria are for classification. We can overrule a classification criteria if we feel that our patient has lupus. And in the diagnosis, we might use some criteria and variables which are not included in the classification criteria. So they help diagnosis, but we can overrule classification criteria. this is just to go back to the idea that we do not have a diagnostic biomarker for lupus. Lupus is very different, and therefore we use the accrual of criteria to define the disease. And here you can see the 1982 classification criteria, which we know very well. These criteria were then modified in 1997 to change the hematological manifestations and immunological disorders, as you can see, and as you will remind, different definitions and different autoantibodies were included. So this we know very well, this we've learned while we were in medical school, and we use these criteria, but we have also learned over time that the ACR classification criteria had some issues and some limitations, mostly related with the fact that dermatologic manifestations were overrepresented. And there was a problem in classifying patients whose disease was characterized primarily by a specific organ involvement, specifically those patients presenting with kidney involvement. They might not fulfill the classification criteria. And the other issue with the ACR classification criteria was the fact that not all patients were presenting at disease onset all the classification criteria. Therefore, the early classification of patients might be difficult. This is the dermatology position on the ACR classification criteria, raising the issues on the differential diagnosis of malar rash, the distribution of discoid lesions, the fact that photosensitivity might be seen as a redundant and difficult for differential diagnosis, again for oral ulcers, and some dermatological manifestations very specific were not included, such as subacute cutaneous lupus. This is the reason why the SLICC group decided to develop new classification criteria, which were published in 2012 and are now known as the SLICC Criteria for classification of lupus. This was a very, very big change in the story of the classification of lupus. In fact, the criteria were, the variables of the criteria were subdivided into two groups: the clinical manifestations and variables and the immunological ones. And to be classified as having lupus, A patients had to add both. So no means of classifying a patient only based on clinical manifestations or only on immunological manifestations. As you can see here, the clinical manifestations were changed as well. And for example, subacute cutaneous lupus was included, and new definitions of different clinical manifestations were also developed. What's very important in these classifications criteria was the fact that it is possible, based on these criteria, to classify a patient as lupus based on kidney biopsy. So the issue of those patients presenting with a single organ manifestations was solved by the SLICC classification criteria. So the patient with a kidney biopsy with antinuclear antibodies or anti-dsDNA antibodies was a patient classifiable as a lupus, and therefore a patient could be included in a trial for treating lupus. These criteria prove to be have a high sensitivity and a high specificity and a good specificity. And this was very important. But we go to the second point, which is another aspect, that is the early classification of lupus. And I would like again, as I did before, discuss the importance of the early classification, and this will bring us to the new classification criteria, by discussing with you a clinical case. A young lady coming to our clinic in December 2012 for a thrombocytopenia, constitutional symptoms, and positive ANA and anti-Rho antibodies. She's treated and she comes to the clinic again in April 2013. The thrombocytopenia is stable. She still has ANA and anti-Rho. And the question here is she undifferentiated connective tissue disease? Well, for sure, she has a systemic autoimmune disease. Is it lupus? Will she ever develop lupus? Which is basically the question we have with undifferentiated connective patients. Well, in December 2013, her story changes, and she presents with thrombocytopenia, fatigue, wrist arthritis, malar rash. She has also anti-dsDNA antibodies. She has proteinuria, low complement, and leukopenia. She has lupus 1 year after the disease onset. So as you can see, she accrued clinical manifestations over time. And obviously, it would have been very important to diagnose her earlier with the dream of changing her story. How do we do this? I'm not going to go into how we could suspect lupus in patients with early disease, but I would like to show you that the classification criteria, which we use for sometimes to support us in diagnosis, do not help us in this story. In fact, if we go to see the sensitivity and specificity of classification criteria in the early disease, both the ACR and the SLICC criteria actually do not perform very well. They have a sensitivity respectively of 76 and 89. So although these SLICC criteria were improved, still we do not classify our patients. We know that patients, as I anticipated, accrue classification criteria very slowly. About 55% of the patients have only one ACR criteria as the initial manifestations of lupus. The mean time to develop 4 criteria, or the mean time to diagnosis, sometimes might be very long. And the manifestations at onset are really non-specific. Arthritis and photosensitivity are the most frequent initial manifestations prior to criteria. Classifying lupus, early lupus, might take a lot of time, up to 4 years. So this might be a problem when we want to early classify patients. Why we want to early classify? I'm not discussing about diagnosis into it, but we would like to early classify patients because, for example, we would like to run a prevention trial, for example. We would like to early classify our patients because we don't want them to be undertreated and then develop a severe organ involvement. So we might promote new studies, a secondary prevention. Obviously, in our clinical practice, we want to understand what will happen to treat the patient. So we want, by diagnosing the patient, change the story of the single patient. So this is to continue our walk through the development of the new classification criteria. Why it was needed that we wanted to develop them, really to go into the early classification. Here you can see the publication you've already seen and you know, and I will rapidly go to this criteria just to discuss with you the most important thing of the new classification criteria. First of all, I would like to underline the fact that they were developed with a worldwide consensus. As you can see among the authors, you see almost really experts from every part of the world were included. The idea was to develop a rule that was intuitive to understand and also to teach lupus. Well, the dream was to have criteria which were not too complicated to be memorized, as we've done over the years with the previous criteria, not primarily relying on the exclusion of other diseases, able to classify early patients, and at least obviously more sensitive, but equally specific to the ACR criteria. Here you can see what you've already learned to know after the publication, the criteria, and you can see some things, and I will discuss these things, that there is an entry criterion, that is the positivity of antinuclear antibodies. Then you can see other things, that the manifestations are grouped. You have renal, you have antibodies, you have serositis, skin, blood. So you can see what you were expecting as criteria for lupus. But you can see another new things. You have a number, because these variables are weighted. And this is a big novelty, because we were used to count the manifestations in the previous criteria as the same. So these criteria should be used only when there is a suspicion of lupus. And now we will go into the entry criterion, which is obviously a new thing. And the reason why there is this entry criterion is basically, in a way, is the feeling that, as it was with the SLICC criteria, lupus is an autoimmune disease and autoantibodies characterize this disease. So it's kind of a dogma that a patient with lupus should have ANA, although this is not really entirely true. But we are discussing about classification. That's why I discussed with you the difference between classification and diagnosis. So ANA has a low specificity, but we discussed a lot about that, and we thought that for classification purposes only and not for diagnosis purposes, the entry criterion of ANA actually was kind of a screening, just to tell you, okay, then there is a big suspicion of the disease. The second point I would like to discuss and to underline that, as it was for the SLICC criteria, as well as for the EULAR ACR criteria, there has to be at least one clinical criterion. So you cannot classify only based on serological criteria. The other point is that we wanted to develop classification criteria which were good for the early classification. And so the variables were derived also from the analysis of early lupus cohorts. To do so, a big international cohort of patients with early lupus was developed to inform the presentation of patients with lupus at disease onset and to identify new variables different from those already known from the ACR and SLICC classification criteria. And what this study showed us is that very often patients with lupus present with fever. So fever became one variable in the new classification criteria, as fever is more common in patients with early lupus when compared with mimicking conditions. And fever was proposed as a first manifestation also from patients, as you can see in the literature. So fever in lupus is a new item, is a common early symptom. Obviously, severe infections and have to be excluded. For example, CRP might help in differential diagnosis. So the right attribution of fever is obviously crucial when counting it as a classification criteria. As I underlined, there is a weighted scheme. So there is a cutoff, and the cutoff is 10. In fact, in the ACR classification system, all the criteria are equal. In the SLICC system, all criteria are equal, although renal histology has a different weight, as I told you before. But here, not all criteria are equal. For example, fever is less specific in anti-dsDNA antibodies. Nephritis is much stronger. So with nephritis, you have 10 and then you are classified. So in a way, however, weighting different clinical manifestations reflects what we do. We do not consider all the manifestations we see in a patient as having the same weight when we diagnose the patient. So in a way, as I anticipated, we wanted this criteria to reflect a little bit our way of thinking in our clinical practice. And the other very important point is that criteria are not independent. So as I showed at the beginning, criteria are grouped into buckets, into boxes, and you have to count only the highest score in each domain. So you're not going to count skin twice. Even if your patient has acute lupus and subacute, you will count only one as a classification criteria, the highest one in each domain. These criteria have been optimized and validated and have been analyzed against the ACR and SLICC criteria to show what actually we hoped they would have had, the specificity and the sensitivity which were comparable to the ACR and the SLICC criteria. So the EULAR and ACR criteria proved to have a very high sensitivity and specificity and have been tested also in early lupus cohort to show a very good performance in classifying patients with a disease duration of less than 3 years. So just to go to the conclusions of my presentations, lupus starts with clinical manifestations. And the story of lupus has started this way by putting together clinical manifestations which are actually occurring in a patient. There are a wide range of symptoms. So this is really a complex disease presenting in different ways. The associations of symptoms has been used to identify lupus because we still lack of a very, very strong biomarker telling us this patient has lupus. So at present, we have to stay with also our classification criteria to identify lupus in a homogeneous way. And now we have this new classification criteria, which may offer the opportunity to classify early disease and perform prevention studies. So I would like to take the opportunity to, again, remind Riconette. Simona has already reminded Riconette before, and I thank her for this. And Simona is part of this network, beautiful network, and she's been working with us over these years. And I would like to invite you to go to the website and see the beautiful things we are doing. This is an amazing project, and to contact Simona if you want to collaborate with us. And she's the referral person in your country for that. And I would like to thank you all for your attention and again for inviting me. Thank you very much.